Dr. Dean began his political career in 1982. He transitioned from being a full-time doc to an elected representative in Vermont, went on to be the state's governor for 12 years, chaired the National Governors Association at that point, and was one of the early innovators around healthcare and economics and the impact of that on his own state. And he took those lessons and transitioned them to a national stage when in 2003 ran for president of the United States. And you can tell his innovation and in this world because he was the one who came up with the idea of using, I guess, crowdsourcing through the internet to fund his campaigns, which of course has become the rule and not the exception. He's had such a dramatic impact on our world around healthcare, and what has really been important for me personally is his linkage between delivery of the highest quality of care, but making it affordable, really trying to ensure that our patients not only have the immediate access today, but also that innovation of tomorrow. And I'll invite him to the stage to join me up here as we spend the next 30 or 40 minutes having a discussion on this. And if you would, for questions, there should be some cards out there. If you want to just fill those in, they'll get passed forward to me. So if you'll welcome Dr. Governor Dean. So we're putting him on the hot seat right away and asking the most fun question of the year. And so how about that presidential race? What do you think is going on there? And maybe your thoughts a little bit on where it is relative to healthcare.
I think Hillary's going to win, and I do have, as a hedge, have my applications for Canadian citizenship in just in case. We actually had a prep call yesterday about what I was going to say when I was asked this question, because I generally try not to be terribly partisan. I had one of the two most partisan jobs in America, where my entire 4 years was devoted to beating people on the other side. And healthcare is actually an area where the patient's supposed to come first, not politics. There's obviously differences in policy. So I have to put away my blowtorch for a minute as I try to characterize Donald Trump without using the word ignoramus, which is not hard. I mean, not easy. Obviously Hillary Clinton knows healthcare policy cold. She knows it inside out. She's been working with it for 30 years. There'll be things that some people in this room agree with, some that don't, but she knows the substance of the issue better than most people in this country, and better than a lot of people who work in the field in some ways, in the big picture stuff. I think Donald Trump doesn't know anything about healthcare, so it's all going to depend on who, if he should win, who he would have around him. Although I suspect that you'll get an ideological approach. And I think ideological approaches never work in the long run. We all have our ideologies. You can't not have an ideology as a human being. But the fundamental problem is ideologies don't get you anywhere. It's all about facts. And that people always used to ask me, what did being a doctor teach me, and how did it prepare me for politics? It was actually great preparation. I cared about the facts, and if the facts, in medicine, or in politics rather, if the ideology and the facts don't mix, then the facts get thrown out, and the patient dies. In medicine, that doesn't happen if the facts don't match the ideology. The ideology and the hypothesis get thrown out, and the facts matter a lot. So that was very helpful in sorting the wheat for the chaff from when I was governor. The other thing was the ability to make decisions and move on. You have a limited amount of time, especially with really ill patients. So you have to make a decision, and you can't make a decision with all the information all the time. That's incredibly helpful in politics, because what happens in politics is you keep asking for more information, so you never have to make a decision. Well, medicine doesn't work like that. The third thing that I brought to politics was not a good thing, and that is we have, many people think doctors are arrogant. I wouldn't use that word, but we certainly don't suffer fools gladly. And part of it has to do with, I think, the MO that many physicians use, including myself, which is the tougher situations get, the more we cope by trying to be controlling. And in politics, suffering fools gladly is part of the job. I once saw two congresspeople debating in the after-hours debates in that C-SPAN thing. And I went back to the office. I work part-time for Dentons, consulting for Dentons, which is this enormous law firm that's all over the world. And I go back and I said, God, you guys, I just saw Congress people X and Y discussing. They don't know anything. This is just unbelievable. I was shocked when I heard what they were saying on television. And the guy looked at me, he was a veteran of the Hill, and he goes, this is the people's house. Well, in politics, you have to be, you have to treat everybody equal. It was Bill Clinton's great gift, is that he could listen to anybody and would listen to anybody and would work with them no matter where they were in life. Doctors are not trained to do that. We are sort of arrogant in this sense. There's only one other profession in the world where you can meet somebody and 5 minutes later they have no clothes on. So, and the power that individuals give you, voluntarily is extraordinary in medicine. And sometimes I think we somehow conflate that with some personal strength. It isn't about our personal strength, or our great attractiveness. It's the MD in the white coat. And most importantly, which we forget, it's the state of the patient who desperately needs to surrender the power to somebody else because they're really struggling. I think not many people in the business, in the policy business, understand that unless they've actually taken care of patients, which I think is really important. So I've sort of dodged your question because I didn't want to say anything mean about Donald Trump, but he could win. This is a serious election. I think anybody who thinks Hillary's going to win, there's going to be a landslide, has been someplace where they've legalized medical marijuana.
That's here, I think. Thank you for that. Both sides have said that they're going to negotiate now with healthcare, whether it's with pharma or hospitals, with this sort of thing, so that they're we haven't done that in the past. And this would be a change, and both sides say they're going to do it. I think we talk about the payers and insurance, whether it's Medicare or private payers, and we sort of forget that we are all the payers. It's coming out of our money. They're the bank, and we're putting the money in the bank, and then they're managing that money. So in some ways, this negotiation is a negotiation on behalf of the American people. And I think we see sort of different perspectives on how we're going to do that. Do you have any sort of thoughts or vision?
I do. First of all, I do think we negotiate now. We just don't negotiate in a direct way. A PBM is a negotiating mechanism. It's circular. I mean, it's sort of circumlocution, but it is a negotiation. Formularies are a form of negotiation. So there are negotiations that go on around price. Here's what I think the fundamental issue that policymakers don't get about drugs. If you look at, when I was practicing, when I was doing my internship in residency, which is almost 40 years ago, and somebody had a big MI, they were in the hospital for 14 days. Today, if somebody has a big MI, they can be out in 3. And those drugs that have been developed, these unbelievable cardiac drugs, have saved billions of dollars. It is true that drugs are very expensive. It is also true that they're a relatively small part of what we lay out for healthcare, and they probably save more money in the long run than they cost. Now, it is also true they extend lives. And there was the famous Czech experiment funded by Philip Morris, which advised the Czech government to increase smoking because it would cut the life expectancy of Czech citizens by 7 years, and therefore their health care bills would go down. There's actually some truth to that, unattractive as it is. That is not what we hope for our patients or our people. But in general, I actually favor getting rid of fee-for-service medicine because I think the single cost is not pharmaceutical companies, lawyers, doctors, malpractice, or any of that other stuff. The fundamental reason that healthcare expenditures have been out of control for the last 35, 40 years is because you keep paying us to do as much stuff as you possibly can. What do you expect us to do? We'd much rather buy a new MRI for $1 million and use it 24 hours a day than hire a nurse practitioner to keep somebody's diabetes out of control so they don't have to go on dialysis when they're 50. I mean, the whole model is upside down. You couldn't sell cars this way. Somebody was telling about selling Mercedes and Buicks or whatever. This doesn't work, this system. My theory about this is if you abandon fee-for-service medicine and use the ACOs to give vertically integrated care, what's going to happen? First of all, people are going to say, a hospital executive has always done, who's been rewarded handsomely for doing no innovations for the last 30 years, and some hospitals have been incredibly innovative. Montefiore and Northwell, which used to be LIJ in New York, are two of them, but there's others, certainly Kaiser, Cleveland Clinic, and so forth and so on. But most hospital executives get paid for not doing anything different than they've done for the last 30 years because they made a hell of a lot of money. All of a sudden now, the first instinct is going to be to cut back on expenses for drugs. Very stupid. Why? How do you save a hell of a lot of money? You actually make people healthier and use drugs more effectively and more efficiently, because that keeps people out of cardiac catheterization labs. And if you do it really well and establish what you're trying to do very early on, you keep people out of Dr. Marshall's care by education for those cancers that can be prevented. So I think that that getting rid of fee-for-service medicine is absolutely critical. If we don't do it, we're never going to get to where we really need to do in cost control. And I don't think, and negotiation will be between the ACO, the consumer, and the pharmaceutical companies. There's always going to be some of that, but as soon as you require, essentially, by economic incentive, because economics run everything, as soon as you educate people through economic incentives that drugs are actually a great thing, and the expense is well worth it in the long run, and that you're actually making people healthier and saving money by using them well and choosing well, and there will be market pressure on manufacturers to deliver stuff that actually makes a difference, not that on the margins makes a difference, because people aren't going to pay a lot of extra money for stuff that just makes a little marginal difference. But I think it's going to change everything, and I think it's going to be actually very good for the pharmaceutical industry.
Let's look a little bit more in the fee-for-service. I've been an employed physician all my life, but so I get a paycheck in a sense no matter what I do. But on the other side, I am metriced based on, just as you say, how many patients have I seen?
Right.
Because our hospital system has figured out if I see so many patients, I'm using so many CAT scans and so many drugs, and they model that. But I'm, even in my world, relatively rare relative to the pattern that's out there. And so there are a lot of forces that want to keep it the way it is now,
Right,
that are going to push up against the fee-for-service. And you hear docs on the other side is they don't want to be responsible for the control over what I'm going to do. I mean, how many times do I have a patient come in and say, well, we're going to do a CAT scan, and the patient wants a PET? I have to talk them out of that. I have to say, well, yeah, that's not the best test. I don't want to do that, but why not? And so sometimes I lose that battle and say, just forget it all. So we don't want to be in that position. So could you talk a little bit about the forces that are against us in shifting away from a fee-for-service and a sort of public opinion and political forces?
Okay, this is another little thing that most people don't understand in healthcare, so I'll share this fun one with you. The reason it's so hard is because the best lobby in the country is not the NRA, it is hospitals. And it has nothing to do with the hospital association, nothing. The reason that, think about how healthcare is delivered. 55% of all healthcare expenditures are hospitals. 80% of all hospitals are not-for-profit. Now, who is on the board of your not-for-profit hospital, whether you're here in D.C. and we're talking about Georgetown or whatever, or whether you're in Ottumwa, Iowa? Who's on the board? The CEO gets and then self-perpetuate. The word self-perpetuates the most prominent citizens in the community, the people who can raise money, the people who are well-respected, and these kind of people will go on boards because, after all, this is a community organization that's good for the community. It's almost universally respected, not to mention the fact that it employs a significant number of people. So when some bill comes before the Health Committee in the Senate that's going to try to control costs or change or get rid of fee-for-service medicine or control the way healthcare is delivered and try to make it more efficient, that senator gets a call and says, you know, Sam, remember that healthcare bill that that fundraiser I gave you in Ottumwa? Well, if you pass this bill, our little hospital in Ottumwa might go out of work, and I'd sure hate to out of business, and I'd hate to tell everybody they had to drive 50 miles for care and that 350 people lost their job because of the vote you cast. Boom, end of story. Who do you think, when they're running for governor and senator, that people go to when they're running? They go to the most prominent people in every community, and of course it's bipartisan because people don't generally pick trustees by what party they're in. So every hospital in America has a built-in grassroots pipeline directly to every public official that is far more effective than any paid lobbyist you could possibly imagine. By far, there is no industry besides hospitals that has a grassroots network that is anything like this, and it was built totally by accident.
Talk a little bit about.
So that is why change is resisted so powerfully in medicine, because the biggest percentage of the money that we spend in medicine is controlled. And I'm all for nonprofit care. Nonprofit care has been shown to be much better in terms of patient outcomes than for-profit care. I'm all for nonprofit hospitals, but the system works, so grassroots resists change. You have to do it state by state.
Yeah, as you know, oncology has a sort of unique set of finances where we don't make the majority of our money on seeing that patient in the time spent. We have an alliance, if you will, with the pharmaceutical industry for, I don't know, 40 plus years. We've had a deal where whatever drugs we prescribe, we get a markup on those. And so in some way, there's been an incentive built all along for more expensive a medicine. In a way, the more money I would make as a practice or as a hospital system. So we have it's not unique, but it's certainly an intertwined relationship in owning or having a piece of the pharmaceutical business itself. And of course, oncologists have been increasingly anxious that in removing that relationship, there won't be adequate support on the other side for all of these patients. And I don't know if you had thoughts.
Well, my thinking is that's obviously a bad system, because if you influence practice because somebody's making money and somebody isn't, that's a bad system. On the other hand, the reason that's terrifying, this is a terrible time to change the system. I think we should change the system, but it's a terrible time to change it because the cost pressure on hospitals is enormous. And I actually think I think this is a total accident, but the creation of the ACO, I think, is going to accelerate the move towards fee-for-service, because now you have an integrated healthcare model that can compete directly with an insurance company. And so you're going to see more and more pressure on specialists and more demand for primary care people to keep people away from specialists. The existing model is you make money on your ICU beds and your cardiac catheterizations and your MRIs. The new model, ultimately, and how soon this is going to happen, I can't tell you, is going to be that you're going to make money on keeping people out of the ICU and not using CAT scans and avoiding cardiac catheterizations, which means that a cardiac surgeon or an oncologist that's making 6 or 7 figures now is going to be under enormous pressure, and there are going to be fewer of them. So, I mean, this is why it's so hard to change. People say we have a doctor shortage. We do not have a doctor shortage in this country. We have a primary care shortage. 8% in 2010 of medical graduates in this country went into primary care. 8%. Why do they do that? Because they graduate with $250,000 of debt, and unless you're practicing internal medicine on Fifth Avenue or Rodeo Drive, you can never pay that back and live a middle-class lifestyle and pay for your kids to go to college. So that has to change. But in order for that, there are always going to be winners and losers. So specialists are looking at this and going, God, if the pressure is downward, how else am I going to make up my salary and send my kids to college and buy a house unless I get this arrangement with the pharmaceutical companies? Yeah. I mean, it's enormous resistance to change.
Yeah. It's one of my favorite little statistics is that the nation of Ireland, a relatively poor EU country, has about 6 million people, and they have 33 oncologists. The city, Washington region, has 5 to 6 million people, and there are, I think, 270 oncologists within our region right here. So this disparity of access and specialty is a big deal. Tell us a little bit, and your experience as a governor, and we're Washington people, so we think nationally typically, but I've been watching different states. I come from Kentucky to watch the impact of the Affordable Care Act there, and the embracing of the Affordable Care Act there, and other states where it's pushed back and forth. Could you talk a little bit about healthcare on a more local, state level, as it relates to cancer care?
Well, it was unembraced by the guy who's now running Kentucky, who this morning got himself in a little trouble suggesting that physical violence might be the remedy if Trump loses the election. So how things change. Steve Beshear, when he was governor of Kentucky, did the best job of implementing ACA than anybody in the country, any other governor in the country. It's extraordinary what he did. We did a lot of the stuff that's in ACA we did 20 years ago in Vermont. We did guaranteed issue, we did elimination of pre-existing conditions, community rating, and we used Medicaid to insure everybody under 18. And that is why Kentucky was so successful. Medicaid is a tough program because it doesn't pay the costs. And there's always, therefore, cost shifting when you have a lot of Medicaid patients, and that's a problem. But it is far better than having to treat uninsured patients, and both from the point of view of the hospital, the physician, and the patient, in terms of getting people in the door, getting them into a rationalized healthcare system, which, of course, in the end saves money because they have something that looks much more like a middle-class approach to medicine, even though it's a loss leader for the physicians. And so I think that Kentucky had one of the highest uninsured rates in the country. And what Bashir did was really extraordinary what he did because it was Kentucky and it's a pretty conservative state. But he basically installed the full ACO as soon as he could. And he got the legislature to agree to it, and he took the Medicaid money. Those states that didn't take the Medicaid money, is fascinating, the politics, because, of course, in a place like Texas, just because it's Texas, the majority of hospital trustees in those beautiful miles, literally medical miles they have in Houston and Dallas, they're all beating up on the governor because the governor refused to take Medicaid for political reasons, and the dish money went away. So now the hospitals are losing because of that. Now it's Texas, so there's so much money sloshing around. They don't lose money, but they don't make what they should be making, and they don't have they have a less rational healthcare system as well. So the ACA is far from satisfactory. I actually think that President Obama's great legacy is going to be the environment, not healthcare, because I think this is a stop along the way, and there's a lot of stuff that wasn't done that needs to get done, and some bureaucratic mistakes were made, and it was essentially written by the insurance agents, insurance industry. But the smart thing that were done, the smart things that were done in ACA that are going to last, I think, and are going to be big steps forward, are one, that health insurance is available for anybody if you can pay the premium. That is, there'll be no more pre-existing condition exclusion, and that Medicaid is understood to be a way of insuring people who can't buy insurance. Now, we still have a very long way to go, but I do think, and I think Bashir got it right away, and he's a very skillful guy, and he did a great job in Kentucky, and Kentucky really was the #1 state in the country in terms of smooth innovation and maximum impact from using that bill the way that I think the president hoped it could be used.
A year ago, we had this meeting, and we asked other folks about what was going to happen in this past year in healthcare, and the answer was nothing. There will be nothing that happens until the election. Well, the election is upon us, and do you have a sense of a pace? Will there be a new discussion and a willingness to discuss, or is it still going to be, one side versus the other and no action?
I think it'll be very partisan after the election, assuming that Hillary wins. Obviously, if Trump wins and then you have a Republican Congress, they can do anything they want. But assuming if Hillary wins, I think Hillary does have some skills, I think, that people don't recognize. When she was a senator from New York, she actually did work fairly cooperatively with Republican senators. And she was criticized during the primary because she voted for some Republican banking bill that had a lot of unattractive features, but she did what a legislature is supposed to do. She went to the sponsors and said, look, this is going to be devastating for poor single women with children. Would you fix XYZ thing? And the Republicans did. And when you do that and you're in the legislature, you're expected to keep your end of the bargain and vote for the bill, which she did. So she gets how the place works. I think President Obama had trouble understanding how this place works. It is not always a system that we like or admire, but there is sort of a code of how you do things, which is maybe not so attractive to those of us who are not in the Senate, but it exists. Hillary knows how to make that work. And so I think there'll be some stuff in healthcare around the edges that can be fixed. And I think certainly the Republicans are going to want to clamp down on spending. In exchange for that, there could be some rationalization of the system that might make some sense. But if you have, again, a divided legislature, I don't think you're going to see enormous steps and big changes, because this is a big change, and most places in the country still haven't fully adjusted to it.
I know you have a great interest in sort of linking public and private efforts, and could you talk a little bit about your thoughts about this opportunity around innovation in healthcare and specifically cancer?
Yeah, I spent a lot of time thinking about this. The pharmaceutical industry is one of the very few industries left where America has an enormous edge. The other one is tech. And it is really important that we continue that innovation. Now, it's unfair. It's true Americans pay because of the regulatory systems or lack of it, and we pay essentially for the R&D for the whole world. But the truth is, the R&D provides enormous numbers of very high-end jobs for really smart people, and it's always good to have industries like that based in your country. And this is, while there are obviously very fine companies that are based elsewhere in the world, this is still the mecca for that kind of research. I think the government needs to get more involved in it, paying in terms of money. I think we need to find ways that universities can continue to do more research. I went to a fascinating place in La Jolla, the name of institution, which I forget, where basically the government and the pharmaceutical industries, it is at Scripps, but there's some name of the institute at Scripps, which I can't remember, but it's a fantastic cooperative. People think, the rhetoric on the Capitol Hill from the people who don't like the industry is, oh, by God, these people take university and research and rip it off. Well, actually, that's not true. What they do is they help fund the university research, and then the university helps fund some, and then they split the money and get paid back. I mean, that's a pretty good system, and we ought to use more of that. I think the financial pressures in the industries are getting rid of one of the problems, which is Me Too drugs. I can remember when I was practicing and the first NSAID came on the which is patented at the time, of course, and then 3 years later, there were 7 of them because it was obviously a profit center. That's too expensive to do. There needs to be FDA reform. I'm not on the warpath about the FDA. I think because of PDUFA, it's a much better organization than it used to be. We do need to allow patient groups of diseases, in my view, and speaking in front of an oncologist, I'd love to hear what you say about this. I think we need to have a different standard for drug safety for patients who have terminal diseases. I think patients ought to be allowed to take more risk because their condition is life-ending. One of the problems is a political problem. Politicians of both parties, but since a certain one is in control now, we'll aim at them. Politicians who run the HELP committee or the committees of reference will haul FDA civilians, not the commissioner, but civilians in front of them and berate them on national television for making a mistake, or maybe they didn't make a mistake. Some drug got out there, it turned out there were some terrible side effects. If you do that, the default position of the government agencies that you're going after, in this case the FDA, is going to be, let's not approve anything because then I won't get yelled at by the chairman of the HELP committee or whatever committee it is anymore. That is a stupid way to run an organization. It's the reason senators aren't presidents is because they do these things in the Senate and yell at people and make public spectacles. That is not how you get the most out of your workforce. And we have to think about how we get the most out of some people who have other people's lives in their hands, and they know it. You don't think it's enough pressure on the people of the FDA who are trying to figure out what to do, so that you have to haul them up and embarrass them when things don't go right? I agree, if there's real corruption, of course, you need to shame people, but I think that gets done too much in politics, and that's a major problem. So I'd like to, clinical trials are too big. We've gone past the risk-reward measure so far to avoiding the risk side that we now have clinical trials that are so big that they're too expensive for all kinds of things. And the industry, fascinatingly, is being disrupted by this because, and maybe not all for the bad, I was fascinated when I went to South San Francisco and was touring through some of these merchant labs where, 5 people, usually 2 scientists and 3 finance guys, rent the lab, borrow a patent from some big drug company that bought it but hasn't had a chance to work on it, see if they can bring it forward, and then make a partnership with the original owner of the patent to see, well, that's not a bad model. It's a disruptive model, but there's nothing wrong with disruption. So there's a lot of fascinating, interesting things going on. I think if there's a fault in the regulation of the industry is that we regulate the industry so much that we sometimes discourage innovation and make it more difficult. And innovation is what this country is all about, and we need to improve innovation and make it profitable, and we also need to make it to restack the deck a little bit so real innovation is rewarded more than it is, I think, right now.
The cost of clinical trials is incredible, and the amount of information we need to collect and the staffing that we have to provide at all levels is remarkable. Of course, those costs get passed off to industry, which of course gets cost passed back to here. So ASCO and others, we are working on simplified common data elements. Could we get the few key pieces that we need that would be in everyone's electronic medical record that would be easy to pull out and use?
Well, that's another problem. Electronic medical records are a mess because you've got 4 firms that run it, and they don't talk to each other, and they claim they want to, and they, of course, don't because they're all proprietary. I just got involved with a small startup that actually forces their programs to talk to each other against their will, and I think that's great. That's a huge problem because, of course, I mean, once you're in the tent, you stay in the tent and try to exclude everybody else. That's something that we don't want to encourage.
To measure value, back to the Mercedes, the Buick analogy, you need to know what you're buying and what it costs. And it's my understanding in the United States that the FDA is not to look at cost and CMS is not to look at magnitude of benefit. So by law, in a way, we're not allowed to see value when new medicines are brought forward. How are we going to go about, as you said, we need to remodel some of our relationships around medical innovation. What's it take to make changes at that level?
This is the most complicated and difficult issue of all. In general, the answer is the free market, but it can't be always the free market in this area because people's lives, generally, we believe that people's lives don't have a price tag. So this is an incredibly complicated answer that's going to sound a little circuitous, which I generally don't do, and I apologize for that in advance. But there's so many moving parts of this problem. First of all, I actually think some of the problem we have with expense works in our favor, and that is there's much less willingness to do Me Tooism because it's too damn expensive. So you can't make your money back now from a complicated, we can pick on oncology since that's what we're talking about. You could pick almost any discipline you wanted, cardiology or whatever. You're not going to make your money back on a drug that extends somebody's life by 6 months in the cancer field, even if you can prove that with very expensive clinical trials. So you don't invest in that anymore. Maybe that's not a bad thing. I don't know. Or you will invest in it, but you won't invest once you get the phase 1-2 trials. And find out that early indications, and there's headlines every 3 or 4 months about a company that does in fact at that and that decides not to go forward, and usually the stock price goes down for a while and so forth. So that's not all bad because the marketplace is making the decision. I generally think that the more transparency there is, the better. What I do not believe, and this is why I'm so much for getting rid of fee-for-service medicine. What I do not believe is this notion that patients make good medical decisions. They, with education and medical support, and they should have as much education and information as possible, you can help them make a good medical decision. My favorite story about my practice is when I was a second-year resident, I was in charge of the CCU one shift, and the biggest nightmare that ever happens to a second-year resident in charge of the CCU is I have a huge anterior MI get wheeled in, and it's the chairman of the cardiac surgery department. And I am terrified. And so in those days, we didn't have all the stuff that you have now, but we had some nitrates and a Swan Gans and some fluids and a few tranquilizers, and we calm them down because all you're trying to do is keep the guy's intracardiac pressure as low as possible, except not too low, and get them through the night so they can begin to heal their anterior wall on their own. And for those who are not everybody here is a medical professional. The anterior wall is a real problem because if it blows out, you have 4 seconds to save the patient, and it never happens. So this is a big, big problem. So the guy's in the hospital. We get him calmed down. He gets through the night, and we're all relieved. And there's no arrhythmias, and okay, we think we're in good shape. All the way down the other end of the hall, which is about at least 50 or 60 yards, of the step-down unit, at the very end, a lady is about to go home after recuperating from her MI, and there's a code 99. Everybody rushes, just like for those of you who haven't been involved in one, which many of you have, but everybody rushes down. They're pumping, they're bagging, they're passing fluids. It's business-like, but it's noisy. Down the hall, having pulled out all his tubes, wheels in a wheelchair, the chairman of the cardiac surgery department, on the grounds that who better than the chairman of the cardiac surgery department to run a code 99 with a cardiac arrest drill, right? This is the kind of logic that doctors bring to their serious illnesses. For a variety of reasons. We talked about the need for control. This is delusional, right? The more medicine you know, the worse patient you are. Why? Because at the time that you need these really serious interventions, you are at your most vulnerable. There is no way that, you can make a decision whether you should go to the doctor to wait or put off a visit to see if it's the flu or if it's really not anything you have to worry about. That's the HSA. The health savings account are great. You can save $300 or $400 a year by not going to the doctor when you really don't need to. And HSA for an oncological decided whether you're going to spend $250,000 or $150,000 on treating cancer is insane. How are you supposed to know? You didn't go to school for 15 years. You don't have 15 years of clinical practice. So I am very much against and very much for providers making decisions, because we're going to make the decision anyway. I do not believe we should make it in a vacuum. I do believe we should educate the patient in every possible way and support but as is usually the way with good doctors is, we need to be a little ahead of the patient. We need to be reading their mind, understanding their feelings. We need to know their family, and we need to help them make the decision, but we're really going to be the one who's going to give the guidance, and we know what decision we want them to make, and we should be honest about that. So that is not the way to control costs. However, I want to say one last thing about this. Patients actually do the right thing most of the time. People talk a lot about end-of-care expenses, end-of-life expenses, and everybody knows what the statistics are, although we don't exactly agree on what they are, but an enormous percentage of our Medicare budget is spent in the last 6 months of life. We agree on that. The fix is not to do the payment studies and the CMS release. The fix is to let the patients do the right thing, and they will. When I was practicing, I'm an internist, but I was in a town about 9 miles away, and that's a long way, and so people didn't drive in. So I saw a lot of patients, 3 generations. We did modest pediatrician stuff, ear infections and stuff. So if somebody came to me and they were dying, and I treated them for 15 years, and they had a chronic disease, and now it was the end of the game, I could call the family together, and I said, I think, this is the end of the game. What do you want to do? And they'd call the family around, and the patient, if they were compos mentis, would say, okay. 90% of the time, they'd say, okay, enough. Somebody would always say, my mom was a fighter all her life, and I want you to put her on a respirator. That was the person from California who hadn't called them for 3 years and felt incredibly guilty. It was about them. It wasn't about the patient. 90% of the time, the patient's going to make the right decision about end-of-life choices. If we keep benefiting by keeping the ICU beds full, or worried about malpractice, so we stick tubes in them and to say that we did everything we could, it's an enormous mistake. Patients are not stupid. They may not be able to make acute medical decisions about which oncological drug to use, but they have an innate wisdom about when it's time to say enough. And the biggest fear I've discovered in my practice was old people are not as afraid of dying as they are that we're going to stick tubes in them and keep them alive against their will. All we have to do is give them not the decision-making power over which drug we use, but the decision-making power. We have to give the American people back the decision-making power over the final act of their life, which is dying. And if you do that, you can save a hell of a lot of money. And if you understand that's what you're doing sometimes in oncology, they will mostly make the right decision.
I want to ask one last question, but then any questions from the audience. Last year at our symposium, our annual symposium, we really focused on value, and we had a patient and patient advocacy panel where the whole morning had been about costs and waste and how do we, reduce costs to make room for innovation. And at the patient panel, we brought up this issue of value, and really all the patient wanted, and sort of pushing back on what you just said, the patient panel was, how can they get more? How can they get more access, more coordination, more support? It wasn't about what would they give up in order to trade off for innovation. And so to me, I will just say that I think the more we can make that individual patient financially responsible for those decisions, the better those decisions can be. And whenever I say that, I get the death squad, how are we going to, make these decisions, or how are patients going to do that? Do you see at any time a shift towards an increasing individual patient responsibility, higher co-pays, higher hospital costs coming forward, or do you see it going more towards a public health single-party shift?
This is absolutely a fascinating question. I don't agree that we need to do higher co-pays and all that stuff, because I think we're already stretching people who can't afford to pay further than we can, especially in the high-end stuff. If it costs $36,000 copay to stay at, to get some chemotherapy drug that has demonstrated benefit, and I can't pay, what am I going to do? I have to decide between my son's college education and my life. I'm going to pick my son's college education. I don't think that is admirable in any way.
What if a popular governor came on and said, if we as a state could cut costs 5% of health care, I'll reduce your taxes? Do you think that would ever happen?
Absolutely not. John Kitzhaber tried it, and it didn't. It was. He went through this whole huge process, and basically it didn't have any difference on expenditures whatsoever. So I don't think that's going to work. I think that here's what I think the problem is. I actually think the problem is us in a lot of ways. Think about this for a minute. How hard is it to get into medical school? It's even harder today than when I got in. And when I got in, it was by far the hardest graduate school to get into. Really, really hard. And they must have turned down 10 really qualified people to accept one. And the same thing is going on today. So that makes us very competitive. We are very competitive people, right? With the exception of pediatricians who are just lovely. And pediatric oncologists who I think are all saints. And I don't know how they do what they do. But the rest of us are really competitive. What is our enemy? It's death. We're not going to take no for an answer. Well, that's pretty tough, because death is an enemy that always wins in the end. I think we do a terrible job in American medicine about talking about death. And I don't think we have to hang crepe for every patient, but I think we as a system give unreasonable expectations because of our own competitive network and what it took us and how we are selected in the process that it takes to be a doctor. We are competitive people who will not take no for an answer. We beat out 10 people who are just as good as we did to get into medical school. We have worked our butts off. Those of us that lead the professions went to high-end academic medical schools where the competition was even tougher, and we will not lose. Well, that's not such a great attitude when you're talking to patients about what outcomes are. So I actually think that instead of having high copays and sorting people out by how much they can afford to pay to keep themselves alive, we ought to be talking about the value for them in being alive under difficult circumstances. There is some point at which chemotherapy is a nightmare for patients who aren't going to get any more out of it. We do not talk about that very much. Sometimes we do, but a lot of times we don't. And I will grant you that oncologists are much more experienced because you know this is inevitable and fairly soon in many cases.
But we absolutely get caught in the trap that you're describing.
Yeah, and so I just think one of the problems here is we've got to rethink what we're trying to do in medicine. And this is not the death panel that Sarah Palin thought was so funny on her campaign. This is about the respectful end of life as well as the respectful beginning and treatment through life. We are not realistic about death in this country, and we have to be realistic. This is not, what was the name of the governor that hung himself? Richard Lamb. Not hung himself literally, hung himself politically by talking about the duty of old people is to die and get out of the way. We're not talking about that kind of a society. Again, we're talking about giving people control, not only over their own medical treatment, but giving people control over their deaths, which we do not do. We take it on as a fight that we should win because that's the way we're put together. That's the way we've been reinforced all our life. I don't think that's a service to the patients.
Dr. Dean, I just want to thank you so much for giving us all your time. You all will thank him for me.
Thank you.